join the share the screen. Make sure it's ready. Yeah. Okay, can we get started, Abrar? Okay.
Yes, sure, Dr. Prince.
Okay. Okay, guys, we're gonna go through the pituitary. I will focus mainly on whatever important for you to know in the pituitary for the pathology side. So we'll focus mainly on the hyperplastic pituitary gland, which mean neoplastic process mainly, and so on. So just remember the normal pituitary. It's small, P-shaped structure that lies at the base of the sella turcica. Here's the location of the pituitary within the bone. So you know that the sphenoid bone is the one who is containing the pituitary gland. Remember the weight about a half a gram, 600 milligram, and the size, remember the 1.3, 1.2, something like that, 1.2 centimeter. So it's around 1 centimeter, the regular normal size. As you see, the location is here. It's very close to the optic chiasm and very close to other nerves like the third, the sixth, the fifth, and fourth. So this is the location which is really important location. Normal pituitary, two morphologic components. You know, it looks like it's one pituitary gland, but actually physiologically, embryologically, and of all function side, it's two. We have two components, the anterior lobe, which is the adenohypophysis, which constitute 80% of the gland, and the posterior lobe, which is the neurohypophysis. So two components, anterior, posterior. The anterior is the one that we're going to focus on today. The adenohypophysis composed of epithelial cells, which periologically coming from the Rathke pouch. So epithelial cells in the adenohypophysis. And the neurohypophysis, actually all the cells are neural, glial cells. It looks like a brain tissue, actually, the posterior pituitary part of the gland. Routine stains that we use, just remember that we use many stains to figure out the pituitary gland. We use regularly, we use the hematoxin iosin stain. And many times in the pituitary gland neoplastic process, we use other stains like the immunohistochemistry, which is kind of antibody against some antigen. We use some specific techniques to figure out some antigens in the tissue. So like we are targeting, as an example, growth hormone. We send some kind of antibodies to the growth hormone antigen. If it's there, it's going to light up by a specific technique we call the immunohistochemistry stain with some color like brown color or red color or something like that. So this is the immunohistochemistry stains. We IHS stain, immunohistochemistry stain, hematoxin iosin stain as the major stain. And we in many times use the electron microscopy to figure out the granules, if it's small, fine, if it's dense granules, and so on. So in routine histology, suction by hematoxin iosin, we see some cells to be pink in color, some cells to be basophilic in colors, and other cells without colors, we call it chromophobe. So pink eosinophilic cells, basophilic or blue cells, and chromophobe or cells without any stains. The acidophils, the cells which stain with the acidophils or the pink cells, usually growth hormone, prolactin, usually the growth hormone and prolactin producing cells stain with the pink color. The basophilic cells, we have the TSH, ACTH producing LH, and FSH producing cells. There are six terminally differentiated cell type in the anterior pituitary. We have the somatotroph that produce the growth hormone, mammosomatotroph that produce the prolactin, the lactotroph again produce the prolactin, corticotrophs produce the ACTH, and so on. Melanocytes, seminotic hormone cells, thyrotroph produce the thyroid hormone, gonadotroph produce the FSH and the LSH. So the lactotroph produce prolactin, mammosomatotroph. This is a mixed type or some type of cells that produce both the prolactin and the growth hormone. This is the regular hematoxin iodine stain in the left side. And you see in the right side here, this is the immunohistochemistry stain. You see some brown color. It means that we are targeting some specific hormones, like maybe growth hormone or something like that. It's lightening up with the brown color. So this is the immunohistochemistry stain. This is the regular hematoxin iodine stain. We have the pink cells. Remember, the pink cells usually prolactin producing cells and growth hormone producing cells. This is the chart that shows the hypothalamus inducing hormone, the pituitary hormone, and the target glands and the peripheral inhibitory hormones. You're going to go through that in the clinical lectures in detail. Just remember, we have inducing hormone at the level of the hypothalamus. We have pituitary hormone. We have a target gland hormone, and we have peripheral inhibitory hormone. The diseases of the anterior pituitary gland, mainly we see the hyperpituitarism and the hypopituitarism. Hyperpituitarism, this is disorder most of the time. It's produced by the excessive action of hormones, extra production of the hormone. Main cause for hyperpituitarism, remember, is the pituitary adenoma. So number one cause of hyperpituitarism is adenoma. Hypopituitarism, deficiency of hormone cause. We have a lot of causes, some of them destructive diseases, injury, surgery, radiation, inflammatory, non-functional pituitary adenoma that cause some pushing of the gland and cause the hypopituitarism. So main cause of hyperpituitarism is pituitary adenoma. Pituitary adenoma, remember, we can see what we call the local mass effect. It's not local mass effect, it's just related to the mass itself, not related to the functions or the production of the hormone. It's so important, the mass effect. When the adenoma reach specific size, size that is affect the adjacent organs, right away we get what we call the local mass effect. It can affect the adjacent tissue. It can affect, you remember the location of the pituitary gland. It's very close to vital particles, like it's very close to the optic chiasm, very close to the major nerves, the third, fourth, fifth, sixth, and so on, brain tissue. So it depends on the areas that being compressed by that adenoma. It can produce signs and symptoms of increased intracranial pressure, like the headache, nausea, vomiting. But to do so, actually, it needs to be large in size, which is unusual. Remember, the elevated intracranial pressure means that there is a good size adenoma or neoplastic process. Many times, as a local mass effect, the adenoma or the enlarged pituitary gland neoplastic process, many times it compress the optic chiasm and cause the most common one, what we call the bitemporal hemianopsia. So the bitemporal hemianopsia is very common findings in case of the compressing by pituitary adenoma into the chiasm. There is a term you need to get used to it, which we call the pituitary invasive adenoma. The invasive adenoma is just an adenoma that is invading or it's going into the adjacent organs beyond the sella turcica. Why? Because many times because of the size of the adenoma or maybe some type of adenoma just pushing itself into an adjacent organ. Many times can produce seizures, can produce obstructive hydrocephalus, and so on. Extension into the adjacent nerves can cause the cranial nerve palsy and so on. Apoplexy is caused by acute pituitary apoplexy, acute hemorrhage into an adenoma. So regular adenoma that can have some kind of hemorrhage within that adenoma can cause severe rapid enlargement of the lesion and cause what we call the apoplexy. Acute pituitary apoplexy is a neurosurgical emergency. It can cause sudden death, actually, in rare cases. Adenoma, as we said, is the most common cause of hyperpituitarism. Just remember, in case of hyperpituitarism, that there are other causes of the hyperpituitary gland. So, can be neoplastic process as hyperplasia or neoplasia or carcinoma. Can be sometimes by the secretion of hormone by extra pituitary tumors. Can be seen by certain hypothalamic disorders. Can be seen. So it's not all the time caused by adenoma. The adenoma can be classified into if it is producing or functioning hormone. It's classified depend on the type of the cell. So multiple classifications depend on the function or depend on the content of that adenoma. Mean what type of cells in that adenoma. The functional adenoma, it's just an adenoma producing extra hormones, functional. Silent adenoma, there is hormones at the level of the tissue, but it's not producing that tissue. So functional mean an adenoma producing hormones with function. Silent, it's an adenoma with the hormones within the adenoma itself, but without clinical manifestation. So in silent adenoma, we can identify the hormone at the level of tissue only. Adenomas, usually in the majority of cases, adenoma actually composed of one cell type. So one cell type gets proliferated to give us the adenoma, like the growth hormone cell adenoma, prolactin cell adenoma, and so on. So usually one cell type. Just remember, sometimes in rare adenomas, we can see more than one cell type. We can see more than one hormone. That means we have two hormones. Many times we have the growth hormone and prolactin being produced together. Just remember there is some type of cells that can produce both of these hormones. So if there is an adenoma with producing two hormones, the most common one is the one that produce both the growth hormone and the prolactin. Pituitary may be hormone negative, If it's hormone negative, that means by immunohistochemistry stains and ultrastructure, we don't find any kind of hormone or any specific lineage to that adenoma. Genetic abnormality, majority of adenomas actually, most of them are sporadic in nature, maybe 5% as a result of inherited genetic defect. Most of the time, the problem in the G protein mutation. So the majority of genetic abnormality actually in the G protein mutation in adenoma. Genetic abnormality, we have a lot of abnormality that can be seen in these 5% of adenomas that can be with a background of genetic. It can be either a gain of function or loss of function. Molecular abnormalities, which is important for us for the clinical side, the ones that are associated with aggressive behavior or aggressive adenoma. Remember, with aggressive behavior, always remember the cyclin D1, the B53. So B53, cyclin D1 are the ones that associate with aggressive behavior. The KRAS mutation, actually, it can be seen in some rare pituitary carcinoma. So what you need to learn in molecular or genetic abnormality, it's seen in 5% of adenoma. The ones that are important, which is related or linked to aggressive behavior, are the cyclin D1 and the P53. The one that is related to the rare type of carcinoma or pituitary carcinoma is the one is connected to the KRAS mutation. So KRAS is in carcinoma, cyclin D1, P53 retinoblastoma gene, and aggressive adenoma. This is important actually. Classification of pituitary adenoma, just remember the most common one. The most common one in adenoma is actually the prolactin cell adenoma. We have the growth hormone adenoma and the null cell adenoma, or the one that producing any tumor. The one that you need to remember also is the least common one is the thyrotrophic cell adenoma. It's very, very rare. The thyrotrophic cell adenoma, it's about 1% of the adenoma. So most common adenomas, growth hormone producing, 15%, almost 15%. The prolactin cell producing almost 30%. Null cell adenoma about 10 to 15%. And the least common one is the thyrotrope producing adenoma. How it's present the adenoma. Clinically, most of the time it's isolated lesion. As we said, isolated lesion. Remember, it accounts of 10% of intracranial neoplasm. So pituitary adenoma actually is not a rare tumor in the intracranium or in the brain. It's 10%. It's seen in 25% of autopsies, either as a silent adenoma or microadenoma. You will see what we mean in microadenoma later on. So it's really not uncommon lesion in autopsies. In 1/4 of autopsies, we can see adenoma. In about 33% of adenomas, it can be seen min type 1. You know, min type 1 with the 3 P's, pituitary adenoma, pancreas, parathyroid. So in about 3%, it presents as a min endocrine neoplasia type 1. The age, most commonly age for adenoma actually is 30 to 50. So almost 30, 40, 50, something like that, most of the cases of adenoma. Clinically, macroadenoma, these are clinically important. When we say microadenoma, it's just a size. You know, microadenoma is an adenoma that is less than 1 centimeter. Macroadenoma is an adenoma which is more than 1 centimeter in size. So it's just a size issue, macroadenoma, more than 1 centimeter. Silent adenoma, as I said before, silent adenoma, it's an adenoma where we see the hormones in the histopathology sections by immunohistochemistry stain, while there is no clinical hormonal function. So it's non-functional, the silent one. We said that before. The null cell adenoma or hormone negative adenomas are adenomas we don't see any hormones in these cells. So the null cell adenoma different than silent cell adenoma. Actually, both of them no function, but in the silent adenoma we see hormones and immunohistochemistry stains in the cells. While in null cell adenoma we don't see the hormone. This is pituitary adenoma. You see the pituitary adenoma in the MRI, and here's a huge adenoma. It will demarcated. Usually adenomas are very well demarcated lesion. Just remember, in case if it's invasive adenoma, the borders are actually not clear. So usually it's well demarcated lesion. The big ones extend superiorly through the ciliary diaphragm into the superciliary, and here it compresses the optic chiasm. 30% of cases, as I said, invasive adenoma. The invasive adenomas are not well encapsulated, not well demarcated, and it's invade the adjacent tissue. Just remember, when we say invasive adenoma, it doesn't mean carcinoma. In the pituitary gland neoplastic issues or neoplastic process, when we say adenoma, it doesn't mean it is carcinoma. It's just invading the adjacent structure. Adenoma in morphology, usually remember two features in adenoma in the histopathology. Very uniform. The cells are uniform because the origin is one cell type. So uniform cellular composition. Very uniform. Uniform cellular, the cells are polygonal, usually rounded, sometimes chords, sometimes shown papilla, sometimes. So the main issue is uniform, but the structures are extremely variable. Sometimes it shows sheets, sometimes shows cord, sometimes shows a tubular structure, sometimes shows papillary-like formation. So that's it. It's just a uniform cells, and the architecture is different. What you need to remember also, the second important factor in adenomas, that is the supporting connective tissue is very sparse. Normally we have a rich connective tissue in the normal pituitary gland, very rich supporting connective tissue. If for the supporting connective tissue, if we do the reticulin stain, we see a rich tissue in normal pituitary gland. However, in the pituitary adenoma, there is a lack, there is an absence of the supporting connective tissue. Prolactinoma, we're going to go through the most important adenomas in real life practice. The prolactinoma is the most common type of hyperfunctioning pituitary adenoma. Actually, the most common adenoma in the pituitary gland is prolactinoma. 30% of adenoma. Remember the presenting clinical features: amenorrhea, galactorrhea, loss of libido, infertility, and you will go through that in details in the clinical lectures. A clinical manifestation may be quite subtle in men and in older women. So in older women, the clinical presentation or the clinical findings many times are vague. So remember, vague clinical findings in pituitary adenoma, always check in men and older women. Majority of lactotroph adenoma actually usually it's composed of chromophobe cells. Chromophobe cells are the cells that are not staining for any stain. Sometimes can take weekly as a pink color. So usually the majority of cells chromophobe, that means cells not staining, or if it's stain with weak acidophilic or pink color. The majority of invasive adenomas, remember, most of the invasive adenomas actually are prolactinoma. So it constitutes the majority of invasive adenoma. Common features in prolactinoma is to see the amyloid deposition, amyloid-like material deposition, and microcalcification. So microcalcification, amyloid deposition, it's commonly seen in the prolactinoma or prolactin-producing adenoma. So we have some important characteristics in prolactinoma. The most common one, that cause invasion or invasive adenoma, uh, amyloid deposition, amyloid-like material deposition, calcification, all of these features of prolactinoma. So the prolactinoma and electron microscopy, the majority of lactotroph are composed of chromophore cells. So the cells are chromophore. In the electron microscopy, we see the sparsely granulated adenoma. So this rare cases we see dense granulated. So usually the granules by electron microscopy are sparse, very few, rare granules. So sparsely granulated usually. Extremely rare to see the granules large and dense. Though densely granulated are rarely to be prolactinoma, usually sparsely granulated. Remember, we use hematoxin iodine, immunohistochemistry stain, and we use the electron microscopy in each case of adenomas. Prolactinoma, remember, mild elevation in the prolactin doesn't mean prolactinoma. We have cases where we see extra production of prolactin without the presence of prolactinoma. Remember the cutoff 200 microgram per liter. Any secretion of less than 200 microgram per liter, always remember other possibility like pregnancy, high dose estrogen therapy, renal failure, hypothyroidism, dopamine inhibiting drugs. So all of these can give us some more production of the prolactin. But the production in all of these cases, most of the time is less than 200 microgram per liter. The somatotroph or the growth hormone producing adenoma, you remember it's second most common functional pituitary adenoma, about 15%. It stimulates the hepatic secretion of the IGF-1, which is the insulin-like growth factor, the somatostatin C, which cause many clinical manifestations. The clinical manifestation, again, you're going to go through the clinical presentation. We see gigantism in children, and we see acromegaly in the adults. It depends clinical manifestation. If it's affecting the kids, the somatotroph or the growth hormone adenoma, it can cause gigantism. It's seen if the growth hormone always before the epiphysis close. The age may be 16, 17, the epiphysis close, something like that. So as is the case of prepubertal children, we see in gigantism generalized increase in the body size. So gigantism in pediatric or childhood, if the growth hormone producing adenoma affecting an adult after the closure of the epiphysis, we see what we call the acromegaly. It's seen acromegaly. We see a lot of change in the soft tissue, in the skin, in the viscera and bones of the faces, hands, and feet. So it's very common clinical presentation. It can cause other disturbances. Remember, the growth hormone, it's not just gigantism or the acromegaly, physical morphology. It can cause diabetes, can cause muscle weakness, hypertension, osteoporosis, and so on. So here is the acromegaly presentation findings. All of these findings, presentation for the acromegaly. The growth hormone classified into densely granulated and sparsely granulated subtype. So in the X-ray microscopic finding, we look at the granules, if it is dense or sparsely granulated. Sparsely means few granules. Densely granules mean too many granules. So densely granulated, sparsely granulated. Remember, in prolactinoma, the majority of cases are sparsely granulated. Here in the growth hormone, usually densely granulated or can be even sparsely granulated. The densely granulated adenoma composed of monomorphic acidophilic cells that have strong cytoplasm growth hormone. Actually, the dense granules are the ones that give the acidophilic or the pink color. The sparse granules are the ones because there's very few granules. That's why we see the stain to be chromophobe. So that's why the prolactin producing adenoma are sparsely granules, very few granules, and are chromophobe. Why? Because it's sparsely granules. The more granules you have, the more acidophilic or pink color you have. Corticotroph cell adenoma, most of the corticotroph cell adenoma actually microadenoma. Actually, the majority of microadenoma, just remember the corticotroph cell adenoma. The somatotroph actually constitute most of the microadenomas. So it's just a clinical presentation of these adenomas. Microadenomas usually in most of the cases, corticotroph cell producing adenoma. Macroadenoma usually growth hormone producing adenoma. The majority of corticotroph cell adenomas actually are are basophilic. It can be densely granulated or sparsely granulated. Usually, the corticotroph cell adenomas are PAS positive. The PAS, the periodic acid shift stain. So PAS staining adenomas usually a corticotroph cell adenoma. The ACTH producing molecule, propionmelanocortin, is stained positively with the PAH. That's why we see the PAH staining disease. Clinically, either silent or cause what we call Cushing disease. Cushing disease, the hypercortisolism, extra ACTH, it goes to the adrenal gland and produce more cortisol, and we have the Cushing disease. So remember the definition of Cushing disease. Cushing disease is always caused when the cause of the hypercortisolism is caused by excessive ACTH production. So there's a difference between Cushing disease, Cushing syndrome. Cushing disease is caused by extra ACTH produced by pituitary adenoma. We called here Cushing disease. Extra ACTH at the level of the pituitary adenoma affect the adrenal to produce more cortisol to get what we call Cushing disease. Nelson syndrome, it's just a large and aggressive corticotroph adenoma that develop after surgical removal of the adrenal gland for treatment of Cushing syndrome. So it's a syndrome. Sometimes we take the adrenal gland for whatever disease, usually for Cushing syndrome. And there is, if we take the cortisol or if we take the adrenal gland, in this case, we don't have the negative feedback in into the pituitary gland. And in this case, in rare cases, we see large aggressive corticotroph cell adenomas. So Nelson disease is seen usually after removing the adrenal gland as a large aggressive type of corticotroph adenoma in the pituitary gland. Of course, in Nelson syndrome, we don't have extra production of the cortisol. Why? Because the adrenal gland is out, but the adrenal gland, the pituitary gland shows a big aggressive pituitary adenoma in this case, but no cortisol production because there is no adrenal gland. It's usually removed for the cause of Cushing syndrome. Other pituitary gland adenomas, they're going to actually, it's in the real life type, it's so rare. And actually, we don't know if it's really real or if it's really present in real life practice. It's very rare. The gonadotroph, the non-functional adenoma that cause the silent functioning adenoma, the true null cell adenoma, non-functional adenoma, remember, constitute 25% of adenomas. Other type of adenomas, you don't need to go through these all other types. Just remember that the other type of adenomas, the rare one, the gonadotrophin producing adenoma, the FSH producing adenoma, the LH producing adenoma. Remember, we said it's are really, really rare, very rare. The non-functional or the non-functional pituitary adenoma. So if we have a non-functional adenoma, it can be either silent adenoma or null cell adenoma. Remember the difference between silent adenoma and the null cell adenoma. The silent adenoma, we have the hormone within the cells, while in the null cell adenoma, there is no hormone within the cells. So it's important to remember these non-functional adenoma. The non-functional adenoma are important because it constitutes 1/4, almost 1/4, 15% to 1/4 of adenoma. It's a common type of adenomas. So how these non-functional adenoma present clinically? Remember, these non-functional adenoma, there is no hormones at the periphery. So usually they present with the local mass effect. So local mass effect. Pituitary carcinoma, again, is really a rare tumor. It's less than 1% of pituitary tumor. The diagnosis of pituitary carcinoma, remember, is not easy at all. Why? Because in many cases we have the pituitary invasive adenoma, and these invasive adenoma, we don't consider them malignant. So the definition of pituitary carcinoma depend on the presence of either craniospinal or systemic metastasis. So to diagnose a pituitary carcinoma, usually we have metastasis either into the craniospinal or systemic tissue. Most pituitary carcinomas, remember, functional. Usually prolactin and ACTH, the most common ones. So most carcinomas functional, most of them produce either prolactin or the ACTH. Metastasis, as I said, it's craniospinal or to the systemic. Usually we see pituitary carcinoma metastasize at the end stage of the disease. Remember the gene that we said that we can find in pituitary carcinoma, which is the key RAS. So pituitary carcinoma diagnosis is not easy at all. It's a rare disease. Sometimes it shows the KRAS mutation. Diagnosis of pituitary carcinoma is not enough to see invasion into the adjacent organ to say this is pituitary carcinoma. We need to see metastasis, either to craniospinal tissue or distant metastasis. Hypopituitarism, the etiology of hypopituitarism, we see either loss or destruction of more than 75 of the functioning anterior pituitary parenchyma. It's not easy to find destruction of more than 75% of the pituitary gland. Either congenital, which is extremely rare, or acquired disease. The most common causes non-functional pituitary adenoma that destructing or destroying the adjacent tissue, or the ischemic necrosis of the pituitary gland itself. Sheehan syndrome, it's a syndrome seen in the postpartum case, postpartum, a lady after a postpartum, right away go into hypopituitarism. It's caused by necrosis into the anterior pituitary. Usually during pregnancy, the blood supply is very high, and right away after ending the pregnancy, the blood supply suddenly get down. And sometimes in rare cases, we get what we call the Sheehan syndrome. The posterior pituitary usually not affected in this Sheehan syndrome. So there is no problem in the pituitary, posterior pituitary. Remember the posterior pituitary, the embryology and the blood supply is completely different than the anterior. So Sheehan syndrome always affects the anterior pituitary gland. Other causes of pituitary necrosis that can cause hypopituitarism, the DIC, disseminated intravascular coagulation, sickle cell anemia. Just remember all of these cases, sarcoidosis, tuberculosis, sometimes metastasis by metastatic adenocarcinoma, lung carcinoma, breast carcinoma, that cause specifically to this area can cause necrosis and cause hypopituitarism. The clinical presentation depend on the specific hormone. Usually, if we have hypopituitarism in young age in the pediatric childhood, we see pituitary dwarfism, which is really rare. Gonadotropin or gonadotropin releasing hormone deficiency leads to amenorrhea. So it depends on the hormone. We see the clinical presentation. If we have prolactin deficiency, we have postpartum failure in the postpartum lactation. Hypo TSH and ACTH, of course, gonna goes hypothyroidism and hypoadrenalism. So it depends on the affected hormone. This is the Sheehan syndrome, whereas we have necrosis in the anterior pituitary gland, and it causes all of the features of Sheehan syndrome. Remember the neoplastic cyst of the ciliary area. These are important cysts. It's common in the real practice. We can see multiple cyst lesion other than or a solid lesion other than the pituitary adenoma. Remember the Rathke cleft cyst. Remember the epidermoid cyst, dermoid cyst, arachnoid cells, and mucocysts. So all of these cysts can be seen in the area. It's not uncommon in real life practice to see either cystic or solid lesion in the location of the pituitary gland in the ciliary area. So if it's cystic, remember these cystic, Rathke cleft cyst, epidermoid, dermoid, arachnoid. If it is solid and cystic, remember the craniopharyngioma and the astrocytoma. So either the ciliary area can be affected by cyst, or other than cyst, solid lesions, neoplastic process, either cystic or solid. Solid and cystic, like in craniopharyngioma. Craniopharyngioma is a very common lesion in the ciliary area, or astrocytoma. So not everything in the ciliary area is pituitary adenoma. If it's cystic, remember the cystic lesion. If it's solid and cystic, usually craniopharyngioma. If it's solid, it is astrocytoma. So craniopharyngioma is a very common slow growth tumor, is 1 to 5% of intracranial tumor. The most are sublacellular without intracellular extension. The majority of craniopharyngioma is seen at 5 to 15 year. It's usually solid and cystic. Size of craniopharyngioma is 3 to 4 centimeter. We see two distinct variants. We see two features. We see either the adamantinoma and papillary, usually all of them benign. Histologically, this is a typical morphology of craniopharyngioma. Basaloid epithelium, and in areas we see squamous-like epithelium. So basaloid-like epithelium with palisading. So palisading basaloid epithelium, and in some area we see what looks like squamous epithelium. So remember, the craniopharyngioma is really a common lesion. It's really seen at the between 5 to 15 at the childhood age, and it's associated in sometimes with the WNT signaling pathway. The histologic variant of the craniopharyngioma, you don't need to do these histologic variant. What you need to know that histopathology, basaloid epithelium with palisading, and in areas we see the squamous epithelium. Grossly, craniopharyngioma, as I said, it's solid and cystic region. And that's all you need to know about pituitary gland. If there is any question, kindly, Abrar, check with the student kind if there is any question.
No questions right now, doctor, in the chat.
Okay, any questions, guys? Okay, so best wishes for you. Thank you so much, Abrar. Appreciate your help. Thank you.
Thank you, doctor.